We now have a few trials that were indeed published these last years on balanced solutions and of course, their comparison with the saline. And the real interest is that we have to discuss what is the right solution for using in our critically ill patients. And when we think at the different composition of these, it's quite interesting because indeed, we have basically saline, which is some sodium, some chloride, and this yield, of course, some osmolarity is there. And we have then the Rubens lactate or Hartmann solution on one hand, and plasmalite on the other hand, which are the so-called balance. And I don't know exactly if you have both of these or which one of these you have here in Brazil. In my country, we have both, basically. In my hospital, I use plasmalite, but nevertheless, I mean, the interesting aspect there to realize is that these other solutions have some difference there. For one hand, osmolarity is somewhat lower, especially for the Hartmanns. It's due to the lower salt sodium composition. And indeed, the interest of that is that the chloride is much more physiologic than the saline solution. On the other hand, because we need to have some buffer to indeed have the same content of positive and negative charges, lactate is there added to balance this solution here. On the other hand, we have the plasmalite, which is a slightly higher for sodium, even though still lower than saline itself. Chloride is relatively lower than in the Hartmann and definitely lower than in the saline. But of course, for electricity neutrality, there is some addition of acetate and gluconate in these solutions. The problem, perhaps, is that we do not know exactly what is the fate or the risk of accumulation of these two substances with these solutions. So, balanced solution versus saline. What is exactly the problem with the saline? Well, in experimental conditions, it seems that indeed the plasmalite and Rubens lactates may have some beneficial effect on some aspects, especially the microcirculation is much worse with the saline compared to the other solution. And also survival of these animals were a little bit lower compared to the other agents. Also for humans, it seems that the chloride content of these solutions seems to be associated with some risk of kidney dysfunction, because indeed you can see that the higher the amount of chloride you give to your patients, the higher the risk of kidney injury also. And regarding the mortality, the same trend was observed in these observational trials, that the higher the chloride load, the higher the mortality in these patients. Well, it's association, it's not proof of context. Some other type of trials were perhaps even more suggestive that there could be a problem there, because indeed, here again, it's not a randomized trial, but it's a huge database of postoperative patients, and what they looked at is patients receiving exclusively plasmalite or exclusively saline on the day of surgery. Okay, these were, of course, some potential risks that I give saline or I give plasmalite to some specific conditions, but nevertheless, I mean, they try to indeed operate there. Among the huge number of patients here, 30 million patients there, 1,000 were only receiving plasmalite, 30,000 only saline, and they try to have a propensity score to really match the patients there. and was observed that there was a slight increase, but a significant increase in mortality there. Very low mortality because of preoperative patients, 3% in the plasma line and 6% in the saline. So this trend was somewhat suggestive that something wrong was present there. And here again, another very huge database here showing that indeed the proportion of balanced fluid here, when it was a high proportion of balanced fluid, the mortality was much lower compared to when it was no proportion at all of balanced fluid solution here for resuscitation here of critically ill patient with sepsis. So again, some data showing that there is some suggestions that plasma light or balanced solutions may be better than the saline, especially when given at high amounts in our patients. And this is a before and after trial, but what they did is that in 2008, they decided to switch from saline, which was almost the exclusive fluid in that area, to balanced fluids, and was observed is that there was less patient receiving renal replacement therapy the year without saline than the year with saline, and that indeed other indices of renal dysfunction were also less present in that context. When we look at randomized trial, the issue is less obvious because indeed we had the first trial was indeed a split trial from the Australian, only if I can say like this, 2,000 patients then, and what's observed is that indeed creatinine was not really different in the two groups here. And the hospital death was exactly the same also there in the two groups. When they looked at the different other aspects, you can see that whatever you look at, there is absolutely no effect here of one crystalloid solution compared to the other solution. Interestingly, still, if we look at the amount of fluid that was given here, there was only a 500 milliliter difference here in between trial and that in the non-steady fluid, sorry, and that the steady fluid here was only 2 liters in 7 days. So 2 liters in 7 days, you can compute the amount per day. So it's only a few milliliters per day that indeed was given to these patients. So the amount that this fluid that this patient received was really quite minimal in both groups. And so indeed, because they did not give really volume to these patients, we may ask ourselves whether or not you could expect to have some differences between the two groups, because indeed the difference between the two groups were that we had 286 milliliters per day in one of the solutions there. So this means that if you look at the chloride load, it was 28 versus 44 in the saline, so only a difference of 16 milliequivalent per day, so that indeed, because of this very tiny difference, you don't really expect any difference in any outcome in these conditions. But the question is, of course, how much fluid do we usually give to our patients? And this is just observational data in patient with sepsis, where we realize that indeed it is not really 2 liters in 7 days, but in a couple of hours, it is 30 to 45 milliliter per kilogram that you can give. So it's really in a couple of hours you can give this, and in other you can see that indeed you can give up to 9 to 10 liters in some of these patients. So obviously it's much more than what was tested in these in that randomized trial. So the question is, do we need to have larger trials to try to go to that direction? Well, we have indeed to think that repeating these kind of trials do not help a lot. So if we don't give a lot of volume, it will not help. And this was one of these trials here, the SALT randomized trial. And so this, again, similar amount of fluid, 1 liter versus almost no difference here in type of volume, but again, you can see that in 30 days it was only 1.5 liters. So I think that they took patients in the streets and they randomized these patients because indeed you can drink 2 liters in 30 days. I think it will be exactly the same aspect. And of course, there was no difference in any outcomes there. So we can repeat this kind of trial very often. We will not see real difference there. But we then had these 2 new trials last year. The SMART trial, very nice acronym. I like to be smart. And the SALT trial there. And the difference was that it came from exactly the same group, the Vanderbilt University in Nashville. And what they looked at, it was indeed the balanced crystal rate versus saline critically patients, and the same in the non-critically patient. Basically, they randomize patient in the ED. When the patient goes to the ICU, the patient goes to that trial. When the patient is not going to the ICU, the patient goes in the other trial. And so what they had is that indeed they had 13,000 patients here, 8,000 patients there. So 21,000 patients total. Well, quite significant trial we admit for that. For the SMART trial, so similar is the critically patient trial, was observed that indeed there was a major difference in the primary outcome, which was major advanced kidney events within 30 days. You can see indeed that it was significant here, but it was only a 1% difference here. The hospital deaths was also almost significant here, but again, 1% difference in the good direction. Use of renal replacement therapy was also a difference here. What was a little bit surprising here, in my mind, is that even though what they call major advanced kidney event here, there was absolutely no difference here in the final creatinine levels above 200% of baseline, exactly the same proportion here, both in survivors and non-survivors, which was a little bit surprising in my mind already there. If we look at the difference in chloride, it was significant here because, of course, 8,000 patients, but the difference was only 1 milliequivalent per liter. So yes, it is significant, but can you really detect this at the bedside? Probably not. And this is something we, of course, need to take into account. There were, as I mentioned, a few question marks there. Again, there was some significant difference in use of renal replacement therapy here. But nevertheless, if we look at the highest creatinine level, it was not really different, less than 1 as a median in both groups. The changes in creatinine from baseline to the highest value were identical. So if we have exactly the same creatinine level, the same change in creatinine level, I wonder why we have so much differences in the use of renal replacement therapy between the 2 groups, because we would not expect this if we have exactly the same changes in creatinine levels in both arms. But nevertheless, I mean, this is what they observed in that trial. Also, again, if we look at the cumulative volume, yes, I mean, it was not really very high. I mean, cumulative volume of less than 2 liters. Well, it's not really a huge amount of fluid you give to your patients. I mean, we were discussing the capillary leak. I mean, there is absolutely no capillary leak in these critically ill patients. So it's not exactly what we call critically ill patients. And I wonder really what were these patients there in that trial. So when we look at confirmatory trial, we have, of course, the SALT trial from the same group, where they shown some difference in saline again of 1 milliequivalent there. The total volume was again not really very different, and 1.5 liters in both groups. And what's observed that indeed, in terms of outcomes, there was no difference in hospital 3 days. Again, some difference in major kidney event, significant again. But again, if we will look further in some other factors, so we'll see that, okay, there was some difference here in sodium, as we mentioned. Interestingly, again, no difference in potassium. Sometimes say, oh, we give a solution that gives exogenous potassium, then it can be detrimental for the potassium, but because the difference in bicarbonate or in pH, this means that also the total sodium, total potassium remains exactly the same in two groups. But you can see here that even though there were some difference in major kidney events, you can see that the changes in creatinine levels were very similar in the two groups. Again, we don't understand really why you can have such a difference in major kidney events with no real difference in the evolution of the creatinine levels between two groups. So perhaps it's something in terms of definition of what is a major kidney event. Interestingly, perhaps, the difference were mostly driven by patients with already some impairment in renal function, because indeed these patients had perhaps some detrimental effect of the chloride compared to the patient with totally normal creatinine level to begin with. And the same was true, and this is, in my mind, even more troublesome, with a patient who begin with some hyperchloremia. And this is really something that begins to be an issue in my mind, because then they knew this patient at baseline had differences in chloride. These patients were already hyperchloremic to begin with. Nevertheless, they randomized this patient to receive more chloride. So on an ethical point of view, it seems to be really abnormal in my mind that they did not exclude the patient with hyperchloremia, because how do you behave at the bedside? Do you give more chloride to a patient who is already hyperchloremic? No. If I have to select the good solution for this kind of patients, I will give a solution with minimal chloride load to a patient who is already hyperchloremic to begin with. If you make a trial with potassium, if your patient begins with a potassium of 6, well, don't give potassium to this patient. Agree? So this is really something that, yes, they found some negative signal, but was it due because of the patients they included who were already, let's say, hyperchloremic and should not receive chloride? Because in the other groups, they did not find this negative aspects there. So we need to be quite cautious there. And when we discuss, do we need more trials? I think we should probably not go in that direction. Or if we need trials, yes, perhaps, but don't repeat the same errors. Don't include these patients there. Please measure the chloride. And I know that some Brazilian teams are participating in some trials on this, and I think that we really need not to repeat that, because indeed we have access to chloride levels at the bedside. We have. It's cheap in internal blood gas analyzer, so we really can measure easily the chloride. And so we need only to be quite careful there, because we need probably better to individualize free therapy and not give chloride to patients who may not receive it. We measure chloride, sodium, and so on, so we can rapidly alter our management based on these measurements. And we should not go for all one size fits all and just give chloride or just give balanced solution to this. So again, if we do this kind of trials, we can already predict that the next trial will be the kind of trials there, with a lot of patients there, showing that indeed this will be something very effective to produce a very nice paper. But of course, we need to pay attention to the design of the trial again. And we developed this with Jean-Louis 2 years ago, where indeed, if we go for these kind of things, either we begin with a normal chloride, and I hope we should not begin with high chloride, of course, and then we increase chloride with a saline. Then, of course, what we should do in these conditions, well, normally we should stop And then if we go in that direction, we will never show any difference between the two agents, because indeed at that time, you stop to give chloride, you go for a balanced solution, and of course you will have minimal chloride load and no effects there. And then it will be again a negative trial there. And so explained by limited amount of toxicity or limit amount of chloride, which is balanced by toxicity of the balanced fluid, and at the end, minimal difference of the amount of chloride and another type of fluids there, so we cannot really show any difference there. If the consequences, of course, at that time is that both solutions can be used, even perhaps if the chlorides can be detrimental in some conditions. Of course, saline is cheaper, and the risk is that in these conditions, some people say that we do not use anymore the balanced one, because indeed it each time a slightly higher cost, and so that indeed it will be for the balance of the hospital detrimental to have a balanced fluids, because indeed both agents are equivalent in these conditions. So in these conditions, we will end up by giving saline to all our patients, including the hyperchloremic patients, and then we will, of course, prevent detrimental to these patients and expose these patients to adverse events. So if we go to the other scenario, then we continue to give chloride, and what we, of course, will demonstrate is that indeed, at the end, hyperchloremia will develop. These patients will probably have higher mortality, explained by huge amount of chloride we give in patients who are already hyperchloremic. And this, of course, not reflecting what we are currently doing in our clinical practice. And this is quite dangerous, because in these conditions, balanced solution will be the only one to use. We will ban saline from this, and this will be, of course, a problem, because saline will disappear because it's toxic. It will increase the cost of our ICU, because we will have only the balanced solution to use, and we will be forced to use balanced fluids in the condition where perhaps we should use chloride, including in a hypochloremic patient. Well, you have to use a balanced one. In traumatic brain injury patients with low osmolarity, yes, you have to use it. And even when minimal amounts of fluids are used, when probably you face these conditions here where you have no difference there. So we have to really be cautious there, and probably the alternative is to know the respective advantage and disadvantage of each of our solutions we use, and to, of course, teach our residents and colleagues how to use the arterial blood gases, to use the fluid administration, and of course to take also into account the brain injury that our patient may have at some point, and know the osmolarity of our fluid solution in these conditions. And I think with this, we can improve the care of a patient, but not with this kind of only one way, exactly the same for all of our patients. With this, I thank you for your attention.
First, thank you for your presentation. It's awesome. And you talk about ABG guided fluid resuscitation. And I'd like to know what you have to say about the use of bicarbonate isotonic solutions in patients with non-anion gap metabolic acidosis or metabolic acidosis due to renal failure. Do you use it, the solutions?
Yes, I mean, it's a very good point. I mean, we sometimes a little bit discard bicarbonate too early. And I think that indeed in patients with renal dysfunction and some acidosis, bicarbonate is a good solution to use in these conditions. One of the points will be, should we try to develop solutions that do not contain chloride at all? Because indeed, if we consider that the chloride is toxic, if we give 2 liters of plasma light, we still give quite a significant amount of chloride to our patients. And at least it's as much as 1.5 liters of saline. The chloride load will be the same. And then, of course, switching to other solutions which are chloride-free may perhaps be something interesting. Bicarbonate is one of these. Of course, giving bicarbonate if the pH is not acidotic is not a good idea. And perhaps also there could be a problem with patients with a respiratory dysfunction, where indeed you need to eliminate the CO2s that you produce by buffering the H+ anion with the bicarbonate. So there's some concern that we need to take into account. Some other possibilities could be the lactate solution that can be indeed one of the sodium lactate solutions. There are some data that indeed this could be somewhat beneficial in some conditions, but we really need much more data before knowing which solution to use in which context. But I really doubt that we will have only one solution for all the patients. Whatever we will have is still a few of these, and that in that given patient at that time, I will give that solution, and later on, perhaps in the same patient or in another patient, I will use another solution there.
Mais perguntas? Os anestesistas, Marcelo, Antônio.
One point I could add perhaps, and I forgot to mention it, is that we also need to pay attention to the other fluids. I mean, we give a lot of fluids for drug dilution and other things like this. And for some of these, we have really very important pharmacological requirements that indeed we need to use either the saline, or we need to use just water or glucose, whatever. But for many, we just have this choice. And then the choice is given to somebody. Sometimes it is just by the habit of the unit to use saline for dilution there. But we, at the end, if we count the amount of sodium embedded in some of the antibiotics, then we dilute it with the saline, and then we give some significant amount of chloride at the end of the day just by this dilutional aspect. And so if you really think that chloride is bad, we perhaps should think at some point at preventing giving this amount of chloride just by this hidden way to our patients.
Então vamos para a terceira apresentação sobre em que ponto nós estamos sobre o corticoide na sepse.